So it's my great pleasure, first of all, to introduce the first speaker. It's my colleague, Belgian colleague and good friend, Lieven Mane. And he's going to tell us something about the huge debate ongoing. What do we need to use now in aorto iliac occlusive disease? Is it bare metal stents or rather covered stents? So can we solve this dilemma with existing evidence? Lieven, please.
So good morning, everybody. First of all, it's an honor to be here and to kick off this flow. And I would like to start immediately with a daily dilemma for me, at least, when I'm treating iliac lesions. What is best? Is it covered stents or is it bare metal stents? So the previous session, I remember that our chairman here and Baha were debating the same topic about bare metal stents and covered stents in the iliacs. And they brought a ton of information, literature, and a very tough debate. What I remember from that debate is that in task A and B lesions, the majority of the lesions, well, it doesn't really matter. Yeah, there's different aspects taking care of your choice. In task C and D, it's more difficult. Historical data that is different and different opinions among all the physicians. So what is best? Well, in our lab, at least, safety of the patient is a very important issue. On top of that, of course, the outcome. Short term, long term. And the back of the head, always the hospital administrator with health economics. So yes, we want to avoid disasters like that, but we have to be honest. How often is this happening, these really disasters? Yeah. Sometimes they even come in a delayed way. Yeah. Patients presenting with abdominal pain, presenting with some tears, hematomas, pseudoaneurysms, but be honest, these are really rare cases. What we face more often, well, that are these calcified lesions. Calcified, angulated, tough lesions to open up. So what is best? What device is best and how can we bring it there? So if you look in the literature about these complications, rare, very rare, 2%, 5%, even less. But if you look a little bit into the literature of the engineers, well, there's some really interesting information to find about covered stents and bare metal stents, things I didn't know at all. And I'm still learning about it, about the stiffness, about the flexibility, and there's definitely differences between polymer-coated or just bare metal stents. Here, articles about self-expanding, but the cover is definitely making a difference in flexibility. Nevertheless, daily practice. Daily practice, the iliac challenge. Highly calcified lesions, sometimes very stiff lesions. What is best? To put bare metal stents or covered? And what are the guidelines telling us? Well, last year, there was a meta-analysis with bringing together the data of some randomized trials. 4 in total, but very heterogeneous randomized trials. And there was not really a good conclusion. To my opinion, because there was not really a sub-analysis. Yeah? If we would take the data and look back and see if there's data available about what calcified lesions, smaller vessels, female lesions, comparing external versus common iliac lesions, I think there might be more clues for our daily practice. I'm not going to dive in detail in these studies, but we all know that the COBEST trial is one of the most important ones and is stated as a landmark trial. But is it actually? Is it really a landmark trial? And yeah, do we have some comments on that? Before we go into the COBEST trial a little bit in detail, I have to say, if you look nowadays on internet, on the literature, there's tons of information, mostly small trials bringing heterogeneous data together. I really think it's time to group the data and to focus on the aspects that really matter. Small vessels, calcified lesions, and complex lesions, although, in my practice, perhaps only 10–15%. Well, all these data and meta-analysis of these smaller groups, not really convincing. Some are pointing out towards the C and D lesions to use covered stents. Although, yeah, if you really dive into details of these studies, not really convincing. Yeah. More or less the same. A and B, no doubt, but the C and Ds, well, there's tendency in some subgroups that there's a favor for the covered stents. Yeah. But even if you look in these trials, you see that the authors or the operators were biased in a way that they have this landmark trial, the COBEST trial, in front of them, and that one is pushing a little bit towards the covered stents in the C and D classes. But if you then look in groups, they're not really going into that debate and still using bare metal stents, well, they come out with the same results. There's not really a big difference, as in this group presenting a similar primary patency for bare metal versus covered stents in the different groups. Small tendencies in reinterventions and ABI change, but all depending on the COBEST trial again. So it's time to look at the COBEST trial. The COBEST trial, a landmark trial. Why? Because it was a randomized trial. But randomized, yeah, maybe some flaws on it. We have to look at that. The good thing is that there was a long follow-up, 5 years of follow-up. So a lot of data that is there to discuss. General conclusion, well, the more complex the lesions, the more benefit from the covered stent group. The TAS A and B, I have to say the TAS B lesions, because the A lesions were excluded in the trial. The TAS B, no real benefit shown covered versus bare metal. So I think, personally, we should look into the subgroups, and maybe there definitely will be benefits, because we all know that these big chunks of calcium that we see, well, there might be a benefit there. Task C and D, well, they claim a definitely basis for the use of covered stent. But from a statistical point of view, well, this is not 100% correct, because the trial was set up as a non-inferiority trial. So the only thing they could say is that they're equal, but not in favor of the covered stents. So in general, what I remember from that trial is that in the easy lesions, majority of my cases, we can, liberal selection. The complex cases, question mark. What else is there? I'm not going to go into the statistics of the trial, but I want to state out that the task classification in iliacs is insufficient to match with our daily practice. So in the trial, the A's were excluded. So if you only keep the ones that were included, there's definitely some inconsistencies between the preoperative screening with duplex ultrasound and the final matching in the subgroups. Because if you see that 34% of 83 lesions in the covered stent group belong to the task C lesions, in fact, should be at least have an occlusion on one side. Well, they only found in the pre-op screening around 15 patients. So there's definitely some flaws in the selection of the patients to the certain to the B, C, or D groups. So very heterogeneous task classification that is not really matching the reality in our daily practice. So it's becoming even harder and tougher to bring out results as on a trial, a randomized trial as this one. In general, freedom from restenosis, well, freedom from restenosis was good in the B group, but look at that. In the task C and D group, there is a tremendous drop after 1 month already. What is going on there? No explanation. Why should the selection of a covered or a bare metal stent cause a tremendous drop in restenosis after already 1 month? Was there insufficient expansion of the stent? Were there different lesions? All question marks. Well, I can imagine that if you have a really big chunk of calcium sitting on that common iliac and you want to open it up freely, that sometimes you're a little bit reluctant of using big diameter stents and high pressures. So there is something a little bit strange there. And what is even more strange is that these patients that were secondary treated, that they show definitely a catch-up in patency that is no longer significant in the long term. So maybe, the covering of a stent is giving some relief or some security in the treatment of these complex lesions for the operator. So, not powered for the superiority. There's some bias. Well, there's also differences in the randomization and selection of the stents. So in general, for me, it is definitely a good trial to show what can happen, but we need more analysis of subgroups. There was the Dutch trial that came out with some results last year as well. Well, also here, it was very difficult to show differences to a lot of reasons. It was a very long trial, more than 50% in one center. So in conclusion, what I can say is that we don't really have a conclusion yet today what lesions we should treat with a covered stent or what lesions we should treat with a bare metal stent, because we just lack the data of subgroup analysis. And therefore, it's good that we gather all the data. So there's 2 trials running currently, the Barista trial and the iliac trial, one with the bare metal stent, the restorer, one with the iCover stent. And if we can bring all this pool data together, hopefully we could do some subgroup analysis and finally find some clues to direct us in our daily practice. So the Barista trial is focusing on the bare metal stent, the restorer, in 200 patients, and we're finalizing the inclusion hopefully in 1 month, and we'll hopefully then can match these 2 groups and see what this will bring us for the future. So is this dilemma solved? I don't think so. We need more data and definitely more debate among us all. Thank you.
Thank you so much. So please take also the seat here with us. So the next speaker is from France, is Dr. Nassar. We will talk about cover stents evidence in iliac arteries, my algorithm of use. More like, or less light in the same field, I don't know.
Okay, thank you. Thank you for the invitation, and I'll try to convince you why cover stent is my first choice in aortoiliac lesions. These are my disclosures, and my big disclosure that I love covered stents, especially the iCover one. Okay, and I'm the co-PI of the iliac study that we will see after. So first of all, the first case of stenting of the iliac artery was published by Palmas in 1987, and 1 year after, the team of Palmas published this first paper about 14 patients treated with the bare metal stent in iliac arteries. And then, 10 years after, we have papers about restenosis in bare metal stents, and authors looked about how to decrease intrastent restenosis, and the covered stent seems to be a good solution to inhibit hyperplasia. And then, many papers in the literature, registries, randomized trial, and meta-analysis. However, and all those, as Levin showed, we have good results for the BMS and for the covered stents. However, all these studies used the TASC2 classification. And I'm a little bit confused with that because, as you know, it's not our daily practice. We have some complex type B lesions and other more easier task D lesions. So for me, I prefer to classify lesions with aortoiliac lesions, iliac lesions with involvement of the aorta, complex iliac lesions, occlusions, CTOs, and calcified lesions, and at the end, some simple iliac lesions with lesions that we can cross intraluminally. And I add another factor is the calcifications. So let's have a look in the literature about results for those indications. I will go quickly for the COBEST trial, heterogeneous lesions. Despite what Levin said, but even we have maybe a little bit more complex lesions in the covered stent group, and they showed better results of primary patency using V12 covered stents, and those results are greater in complex lesions. Okay, what about the DISCOVER trial? DISCOVER trial is a recent paper published in the European Journal of Vascular Surgery with the aim is to prove the superiority of the covered stent. But when we look for the paper, which is interesting, that 6 patients crossed from the bare metal stent group to covered stent group, and none in the other direction. And the reasons to switch from the bare metal to the covered stent group is the fear of rupture, the fear of distal embolization. And then authors did not show any difference between both the groups. And the multivariable analysis showed that covered stents tends to have lower risk of restenosis without statistically significant difference. But what is surprising, that we can see that moderate and heavy calcifications are protective factors for restenosis. And authors explain that by the low rate of events. So my question is, if we have a little bit more events, the difference between the covered stent and the bare metal stent, it will be significant or not? This European multi-center retrospective study, the COBRA registry, included more complex patients in the covered stent group, CTO, TASC-D, severe calcifications. And authors said that covered stent and bare metal stent showed comparable midterm performance in terms of primary patency and TLR. And this multivariable analysis showed that we did not have any advantage to use covered stent. However, when you enter the factors like CTO, TASC-D lesions, and severe calcification, we can see that we have better results with the covered stent when it is about TLR. Another paper with a retrospective paper with a propensity score matching, not showing any difference in terms of primary patency between the groups, but when we analyze the subgroup of severe calcifications, we have a large advantage for the covered stent. And these results are again confirmed with the iliac registry, which is a big registry with, again, a propensity score matching that showed the same thing. No difference for the simple lesions, but when we have moderate and severe calcification, we have an advantage of the covered stents. Okay, those results about aorto-iliac lesions. And what about lesions that are just in the iliac axis without involvement of the aorta? This is a monocentric retrospective study, but we have only CTO, iliac occlusions, severe calcification only 10%, but we have a good primary patency at 24 months of 97%. And finally, for those lesions just in the iliac segment, we have this study comparing the bare metal stents and the covered stents. And we can see that we have a better primary patency with more complex lesions when we have CTO more than 3.5 centimeters, when we have total lesion more than 6 centimeters, and when we have calcified lesions. And authors concluded that covered stents have a higher midterm patency when we have complex lesions and CTO. So, according to this data, what is my algorithm? When I have simple lesions of the iliac that I can cross intraluminally, I will go for a bare metal stent. When I have aorto-iliac lesions, lesions of the iliac artery with involvement of the aorta, and when I have CTO in the iliac artery, personally, I will go for a covered stent. And when I cross the lesions intraluminally with very high calcified segment of the iliac artery, I prefer to use the covered stent. That's my actual algorithm. But we have to take into account that we have a new game changer in the calcifications, which is the IVL. Yeah. The IVL maybe will change our way to treat the iliac arteries, but we still need more data and we still need more evidence to change my algorithm of the iliac artery treatment. Just a reminder about the ELICO study, which is a prospective multi-centric European study. The aim of this study is to evaluate the safety and efficacy of the iCover in iliac lesions. Lesions with the aorta were excluded. Actually, 223 patients have been enrolled until March 2024, and we need 17 patients to end the inclusions. And I want to thank all the participating centers, my co-PI, Professor Zeller, and the iVascular management team Ms. Domingo and Ms. Pitch for their involvement in this project. And to conclude, I think that covered stents have better outcomes for complex aorto-iliac lesions. In my practice, even if it is rare, but I prefer to avoid rupture of the iliac artery. And I think that using covered stent, it will allow us to have, if we have restenosis, just in the, it will be a restenosis in the edges of the stent, which is easier to treat than a total in-stent restenosis. The iliac study will bring more data about covered stents with the interim results that be communicated in the Link conference. And as Leven said, that it will be interesting to have a comparison between the bare metal stent for the patient included in the Barista trial and covered stent for patient treated in the iliac study. Thank you for your attention.
Thank you.
Thank you very much, Baha. So before we go to the questions, I think it is time for a little voting. So we want to know what you are doing in your daily practice. So take your card. So I give you a clinical situation. You have bilateral common iliac high-grade stenosis, 96% on both sides, right at the ostium, not extending into the aorta. The external iliacs are looking quite fine. You have really a grade C calcification, so severely calcified. So what you're going to use in this particular situation? It's a symptomatic patient. We not go in details for the patient, but so bilateral common iliac, 95% stenosis, severely calcified, right at the bifurcation, but not extending into the distal aorta. So who is going to use in this situation a bare metal stent? You show the purple side. A covered stent, you are showing the magenta side, sorry. Is it possible to get some more light in the auditorium? Probably not.
Mostly magenta. Yeah, magenta is the winner.
Although magenta is indeed a little bit, the majority, yeah. But still you see that this debate is quite interesting because a substantial amount is still opting for bare metal stents. So do you have questions or remarks on this topic?
I have a question.
Or comments?
You have a question first.
I have a question. For those who voted bare metal stents,
yes,
the blue.
I can ask if you have reimbursement of your bare metal stents and if it is the same price between the BMS and the cover stent.
So in other words, is price make any kind of difference in your choice?
Yes.
Is price make some difference in your choice for the blue ones, the bare metal?
Blue, yes.
Ja? You have it?
It's a question. No.
Yeah. No. Okay. There's somebody who voted in favor of bare metal stents in terms to answer the question.
Or to make it easy, we can say, show your blue card if price, health, economics are playing an important role in your decision making. Blue.
Blue, only blue. Yes, yes.
Yeah, some.
Few, yeah.
20% of the auditorium, so 80% very rich people, 20% poor people.
Absolutely. Oh, very, very good liars.
Yeah. Jan, you have a question.
Congratulations for the presentation. Leven, I think you make the point. And the point also is about the task classification. And the task for iliac is a mess. It's a mess. And so far, as you said, we didn't have convincing data. But I can add one point. It's about a technical point. I don't use cover stent, to prevent thrombosis of stenosis, but I use cover stent because of the redo procedure by crossover. A nightmare for interventionalists is a redo procedure by crossover when you have to perform the crossover into the stent. And you can have the guide wire into the strut. You can have a crush of the stent. It could be a nightmare. If you use cover stent, you avoid this nightmare, and the redo procedure is easier. What do you think?
Well, I partially agree. If the stent is very recently implanted, then I agree. Then if you do a crossover, there is a high risk of getting entangled. So what I do then is go always with a loop through the stent. But once it is, let's say, 3 months past, I believe it's fixed to the wall. There is enough fibrin tissue within the struts, and I personally don't have this problem anymore.
This week,
Exceptions
I have
exist.
this bad experience with an old stent by a retrograde access. It was not a crossover in this case. It was an external iliac stent implanted 2 years or 3 years ago. And we go inside the strut, and it was dramatic with an old stent this week.
Exceptions exist, that's for sure.
Questions or remarks?
Yeah.
There,
Isa?
Yes.
Dr. Isa?
Okay, thank you for your really interesting session. So we have said that probably calcification and thrombus favors the use of covered stent. And my technical question is, the crossage, the subintimal crossage, makes any difference in your choice, in the decision-making process?
Good question. So subintimal recanalization,
Yeah.
is it important in your
Yes,
algorithm to
I think-
decide which kind of stent?
Yes, I think I have 3 factors that you have to take into account. If it is how to cross the lesion, if it's intraluminally or subintimally, the calcifications and the length of the lesions. And that's in my algorithm, I take into account the 3 factors to use covered stent.
For me, it's different. I only take calcification. The crossing for me is the behavior of the prepping balloon. If the balloon is opening up very easily with low pressure, then for me the risk of bursting, of problems is low, even with calcified lesions. And the length, I'm not really agree on that one. Even more, the recent information that we got on in London about the intravascular lithotripsy and the iliacs was quite striking for me in a way that the bailout stenting was low, so that was good. But if they stented, they didn't use, I think this is my microphone,
So here, I think.
or this one, yeah. They didn't use covered stents, although it was like 70% task C and Ds, or even higher. So, so the lithotripsy changed definitely the calcium, the compliance of that vessel. So that means that the covering is, or at least the operators there, didn't think that the covering is important for the long term. And they choose bare metal stents just to keep it open. So that for me is also thinking, why do we need the covering? If you just change the compliance and you can, keep it open, there's no need for covering.
If you change the compliance, because in some cases you have late rupture at 24, 48 hours.
Yeah.
So if you change the compliance of the classification, I totally agree. Maybe
It's
you
not
don't
possible,
have to cover.
Yeah.
Then you need to
So-
cover.
There was a question in the room there. Can we
Yeah.
have the microphone? You have it?
Yeah, I have.
You can introduce
So-
yourself, please.
Yeah. I'm Dr. Virendra from New Delhi, India. So the question is, whenever we are doing a bear with some calcification, we don't go up to nominal pressure with the fear that it may rupture. That's the biggest challenge which we see using a bare metal. I mean, you guys have already covered in your talk. So does everyone keep a backup covered stent? Because the thing is, whenever I'm doing a bear, I'm always afraid that it may rupture, so I do an under treatment. And that is going to affect your trial as well. Like in case if you rupture, is it going to get converted into a covered stent?
Yeah, so I think if you do treatments of complex iliac cases, you definitely need backup with covered stents. But personally, if I have a huge rupture, I prefer a long stent, a long and a big one. So I prefer then more like a self-expanding 10 centimeter stent, because then you have enough landing zone, proximal and distal, and you avoid progression of the tear. And in my hands, it's safer than using shorter balloon expandables.
Good approach.
So the second question is, you will go to the nominal pressure all the time to crack the calcium when doing even the bear? Or you will be doing as an under? Like you have pre-dilated, then you're going with a balloon-mounted stent, bare metal. So will you use the same pressure for both?
Nominal pressure.
When you're
Nominal pressure or not, yeah. For both.
It depends.
I mean, your
if
confidence
you
level
make
with
preparation of not, if you prepare the artery, or if you go for a primary stenting,
Yeah.
it's different.
More questions or remarks or points of disagreement? Yeah, in the middle of the auditorium. Arno.
Dr. Kersman from Belgium. Good morning, everybody. It's more a remark than a question. I didn't hear nothing about the internal iliac artery. So when the internal iliac artery is patent and I have to stent the iliac bifurcation, then I prefer to use bare metal stent. I guess you agree.
Yeah, there's definitely more topics to discuss about bare metal stents. Also, if you have to protrude a little bit into the aorta, and there's big sacral arteries of a very big lumbars. Of course, if you use covered stents or even if you use T-wraps, all that is lost. So, but that's for me not a major point. Yeah. The hypogastric, I try definitely to preserve it. It's there, definitely.
I also have a question for you both, or you three of you. So we are always limiting the debate into covered stents and bare metal stents. But is there a class effect? I would like to say, are all the covered stents the same for you? In my experience, in my knowledge, everybody is always referring to the fantastic COBEST trial, but it is probably with the most old-fashioned covered stent of the world and the history. Yes. So what about the new, the iCover, the live stream, the VBX, the Bentley B-Graph Plus? Are there real important differences there in your daily experience? And based on what do you select the right covered stent for the right indication?
But for me, it depends for the stents, but also the access. Because the V12 is a good stent, but it is in 7 French for 10 millimeter. Okay, you will go in 7 French, but to go out, it's difficult. And you have more access complication with. What I love with the iCover stent, you have which is positive with the V12 stent. It's covered from inside and outside. Mm-hmm. He have a good radial forces. And he has the positive thing from the big graft, which is the 6 French introducer until 8 diameter. And for the other thing that which I hate a little bit with the big graft, it's that we do not have inside the PTFE. So when we make a crossover or something like this, it will a little bit in something more difficult.
Yeah, addition to that is also the balloon concerning. Yeah. Because the Oceanus 35, no shoulders. So you be much more accurate according to the stent length. So this is important because if you are playing with the plaques and close to the hypogastric arteries, if you have very huge shoulders, you can dislocate the plaque over there and cover the hypogastric artery.
And the visibility also of the stents.
Yeah.
So when you have obese patient, the visibility of the stents,
the
markers, it's interesting to have markers.
Yeah.
Jan, you had a question or remark?
You are right. The platform matters, and you show the ICE RCT from Krakenberg, and this study it seems to have an advantage to self-expandable stent rather than balloon expandable stent. Makes sense to use cover self-expandable stent rather than balloon expandable cover stent? What do you think about it? Because we have to speak about the platform.
Well, at least in this area of the external iliacs, I'm a fan of self-expanding stents. I'm not a fan of covered. I use self-expanding stents definitely when I'm going to the area of the hip flex in the iliac. I'm not a fan of self-expanding in the common iliac unless it's a total occlusion from the top to the bottom. Then I sometimes use one long self-expanding, and that is depending, of course, calcium load, but most of all depending on the behavior of the prepping balloon. If it's soft, if it's opening up very easily, then I sometimes put like a 12 centimeter self-expanding long stent.
Thank you very much, Lieven. A final question for Professor Riambeau to make also the bridge to the next session. So we are talking about covered stents. We know in general there are two main indications for these type of stents. it is the treatment of iliac occlusive disease, what we discussed right now, and then the FEVAR, BVAR, whatever. So do we need a separate covered stent for one indication and the other, or is there some category of covered stents doing both jobs in an as good way?
I think it's a good question, but different fields, but different indications. But always for talking about the fenestrated or you know, breaching the stent in general, we prefer to play with dual coverage inside and outside, just to avoid any kind of conflict with the struts if you need to revisit the stent for any reason. So precision and radiopar markers are very important, just to allocate and to face with the markers for the main body stent graft. So I think flexibility is a very good point too, even for the delivery system, as well as the flexibility of the kink resistance, especially for branches. It could be very important to take in account. So definitely, in my experience, we can see in the next session and probably my presentations, is at the moment I cover is all prefer the stent for breaching the stent, FEVAR and BVAR too. Waiting for the 77 length could be very soon available in the market. Okay, so we will move forward with the next session. I invite my colleague and friend, Professor Lucas. Thank you. And we start with the EVAR treatment approach.
Yes, thank you very much, Vincente. It's a great pleasure to be here with all of you. And the first speaker in this session, which we leave the aortic bifurcation and we go a little bit upper. And the first speaker, this is my good friend Nikos Paris from München, Germany. We speak on the FEVAR, BVAR. You will explain the different indication and technical aspect. Please, Nikos.
Thank you very much, Eric and Vicente, and to everybody for being here, and especially for iVS for this amazing meeting. This is a great audience, and thank you for the nice discussions. So we're going to jump into a completely different topic, FEVAR, BVAR, and what is my approach, how do we choose its technique. And we know now that we're talking about complex aortic aneurysms, which are more the pararenal, juxtarenal, and type 4 aneurysms. But what we are talking about when we're talking about FEVAR is more this indication, short neck and juxt and pararenal aneurysms. And this has now been introduced in the recent guidelines that were published from the European Journal of Vascular Surgery a few weeks ago. And this is, there is also an added chapter on complex aortic disease, which I recommend that you all read. So what kind of stent grafts do we have available for these segments? We have, of course, the off-the-shelf devices, which are pictured here, the ones that we know from a few years now, the Cook, the Artivion Insight, and now we have a few more players on the market, either coming up or already there. And we have the custom-made devices, which means these grafts are produced for the patient specifically and they match his anatomy. And there we have also 3-4 players now in the market that give very good results. So going to the custom-made designs, which you can see here, they are, as said, can be offered, they have several advantages. They can be offered in raw profiles, they can have preloaded catheters, but they require 8 weeks to 3 months sometimes to get delivered, which leads to a substantial delay in treatment of these patients. What the options, what are the different ways that you can address the target vessels? You can have a fenestration, which is, or a scallop, and these come in different sizes, 6x8, 8x8, or you can have a huge 10mm fenestration, which is rarely used, or a scallop if you just want to extend your repair higher and just make sure you don't cover a celiac trunk, which is the top of your repair. Then you have the branches, which are mostly the first branches that we ever used in the first designs were the outer branches in diameters 6 and 8 most commonly, but you can also get them in 10mm. And now, lately, we also have the inner branches, which are also the same design as an outer branch. The only difference is that the diameter of the total graft is different in these cases, and that it starts from the inside and goes to the outside. So it's a little bit different in terms of the design, but not a huge difference in the effect. This is how the plans from the companies look like when you do such a repair, and you can appreciate here that you have the three fenestrations and the scallop, or the 4 fenestrations. The good thing about the CMD, the custom-made devices, is that you can put your branches wherever it is needed based on the anatomy of the patient. And of course, you can modify the diameters. So the big first question that was posed to me was, how do we choose one or the other? How do we go for fenestration? When do we go for fenestrations? When do we go for branches in these patients? So there is one basic rule that we have to follow, and that is, when you have a wall that is, and a graft that can oppose the target vessel on the wall, then you go for a fenestration, because the risk of endoleak there is low. If you have a thoracoabdominal aortic aneurysm, and this aneurysm is and your graft is not expected to attach to the wall of the aneurysm, then you have to go with a branch in order to bridge that gap between the 2 vessels. And if you do not do that, and you go on with a fenestration, it's a very high risk that you will have some kind of endoleaks in this area, because your seal zone is actually only the attachment of the bridging stent into the fenestration. So going here, another important thing that you need to consider in this treatment is how you taper these grafts, and this is also something that you have a privilege with when you do CMD design, and you can do a tapering, where you should also be aware to make sure, even if you have a fenestrated design and you want to go into and you want to attach the graft to the target vessel, you need to plant the graft this way. And this was a graft that was suggested to us by the planning center, and we said, no, this is not correct, because it's just too thin at that level. So you have to go on and correct this plant to make it wide enough at the level of your fenestrations to attach the wall. So planning of this device is not just a simple thing that you give to the companies and accept them to do the work for you, but you have to be proactive in planning those cases. So also, of course, looking at your CT scans with respect to the decision how many fenestration, how many branches you're going to include in your repair. And here you can see, it might seem in the axial images that this could be a good aorta, but if you look at it in the sagittal mode, you will see that there is an inconsistent diameter along the renovisceral segment, and you do need to go for a higher repair in these patients. Things can get more complicated. There was a patient in our institution who had a very weird anatomy. He had multiple right and left renal arteries. He also had a pelvic kidney, with the kidney in the pelvis indeed, and a big renal artery coming off the aortic bifurcation. I guess one or the other has seen such cases. And we had to go with a more complex repair in these patients. After getting his frozen elephant trunk, we were able to do a TEVAR in this very challenging anatomy using a through-and-through wire and establish flow dart to the celiac. But then the next challenge was, of course, to move on with the repair of this anatomy. So what did we plan for this patient? And these are the advantages of the CMD devices. We planned 2 fenestrations for SMA and celiac. We planned an antegrade branch for the right upper renal artery, a retrograde branch for the right renal artery from the iliac lymph, and an antegrade branch from the aortic from the bifurcated graft for the pelvic kidney. And this is the repair. This is how we did the pelvic renal artery, and at the end completed the repair. What is also important is that you decide to go higher at the right moment, and this is an example of how a publication in the early years demonstrated that even if you go higher, you do not necessarily significantly increase your rate of complications as long as your experience has significantly increased. On the other hand, if you have a fenestrated case that has been done incorrectly, with example, with a tooth fence and a scallop, which is something that we used to do back in the days, and you have to go back afterwards to rescue that with another fenestrated branch repair, then the complication rates are much higher. And this was a small series from high qualified centers that showed that doing a second redo fenestrated or branch repair is associated with a high risk of complication and spinal cord ischemia. This was a case that came to us with a type 1 endoleak after an anaconda repair of a juxtarenal aortic aneurysm. The diameter had now reached 11 centimeters, and we did this design for this patient where we did 2 antegrade branches, 1 unilateral device, contralateral limb, which was actually just a branch of 10 millimeters, and 2 retrograde branches for the renal arteries. And you can see here the final result with the anaconda in place and the branched fenestrated repair again. So another decision, another way we decide is for fenestration branches is how the vessels are oriented. If you have a very cranial-oriented vessel, you're of course going to go more likely for fenestrations. If it's going to go downwards, branches are of course welcoming. And another important thing is to know that this is a treatment that of course produces very good results on the long term with very low mortality and morbidity. Fenestrations are, if you have the choice to go for both, you need to also keep in mind that fenestrations have better, the target vessels are expected to have a higher patency with fenestration compared to a branch repair, as you can see here. And this was showed by this publication from Panuccio already 2015, and also the new studies confirm those results. So if you have the option to go for one of those, probably fenestrations are the way to go. But there are also cases where you might have a fenestrated a neck which could be suitable for a fenestrated repair, as in this one. But on the other hand, it is extremely difficult to predict how a fenestration is going to sit in this anatomy. So in these cases, of course, it's an option to go for a branch repair to make sure that you can get that target vessel. And that's what we did in this patient, where we were able to indeed to get that vessels only by doing a branch and catheterizing at this very angulated curvature using the branched repair. And this is how it looked at the end with these results. Another important factor, of course, when you take into account the fenestration fenestrated versus branch repair, is the waiting time that we have for these grafts. We know that there is a risk of death in these patients, depending on the size of the aneurysm, and this has to be accounted for. If you have an 8 centimeter aneurysm, you can of course not wait 3 months for CMD fenestrated devices, and in these cases you should also evaluate the option of the off-the-shelf device, which we also have available as previously discussed. Readily available, you can do quite a few variations with them as well, and of course you're not very restricted by the anatomy as you are with the fenestrated repairs. These are the branches that are available, and of course what you need to know in these cases is that you are covering much more of the thoracic aorta, but you can treat very challenging anatomies like this 10 centimeter post-dissection thoracoabdominal aortic aneurysm with complete true lumen collapse using an off-the-shelf device, using a bunch of adjunctive maneuvers to go from the true and false lumen, and at the end complete the repair as you can see in this patient. Steerable sheaths are important, and I think that's something that we need to put into context when we are talking about new bridging stents, because more and more you physicians are making their approach completely from the transfemoral. I still like very much the transaxillary approach, but we do know that this is an approach that is gaining ground. So we need to adjust our bridging stents to low profiles that can do these curves and be able to adjust for these anatomies. This is a few techniques that have been suggested on how you can do that, using a steerable sheath, or using a steerable sheath also with the help of the stabilizing wire within the sheath. The secondary problems of bridging stents could be relevant. You see here a big graft that ruptured, and this is something we know from the early experience of this graft, and this has of course changed, but it's still a big issue that we have to be aware of. And we did discuss this paper about the fenestrations and the branches, but we also know that these patients, that the fenestrations are going to be on the long term a better way to go. This is what we expect for branches in terms of patency, and these are the data from a post-marketing study that we did on the T branch. And you can see that the renals are the most sensitive vessels, and these are the vessels we need to address with specific stents, and renals are in our practice now more a self-expandable stent for branches than balloon expandable stents. The eye cover is a graft that everybody knows that has now a very good low profile that we can use also with up to 12 millimeters diameter with the post dilation, and it comes with a sheath of 6 friends, and the larger size is at 7 friends, which is of course very handy, and this is something that has helped us in a lot of cases go through very difficult anatomies. So I will spare you the last slides because Eric is becoming a little bit nervous with the time, understandingly, and I will just conclude that when you do these cases, you have to be very aware of the anatomy. Don't compromise your seal zone, but also don't compromise on the security of the patient in terms of waiting, and do it right the first time. You try to make good thoughts on how this is going to go during the operation, but also on the long term. And of course, fever is the way to go if the anatomy allows it. And I thank you for your time.
Thank you, Nico. So please take the seat. So now it's my pleasure to introduce my co-moderator, Eric Ducasse, from France, Bordeaux. Good wine. Why more evidence is needed in fever?
Yes, we need more evidence. I mean that remains some field of challenging for the fever procedures. I see that there are some remaining challenging parts. First, this is the indication and anatomies that have been mentioned by Nikos. After, this is how to follow very strictly and carefully all those treated patients, and also some remaining challenging points regarding specifically the devices we may use, and especially the bridging stent. There's the first, of course, it remains some very challenging cases, and you mentioned that, especially the angulation, the targeted vessel orientation, and also the lumen, the remaining lumen, that may be very challenging. And here, when you do the sizing or the pre-sizing, that may be reported, like in that case, due to the double angulation, that could be, it remains, the planning is very challenging, I guess. And finally, the sizing could be rejected, and you need to find another solution, or you may contraindicate the case. Once again, What remained challenging, this is still the indication, and indication is really led by the anatomy, and again the angulations also to focus on the targeted artery, once again the diameters, the angulation, the short bifurcation, all those aspects, and also the accesses, but fortunately also we may use the high-vel technique and predilatation, that may help. After, maybe we have also new fever available with now quite low profiles. We also have bifurcated fever that may help, especially to do fever in after EVAR and landing in both previous legs, and also after surgical graft. That could be very indicated. And also still remains some surgical option or some abstention for treated patients. After the other problem, what is needed, this is how to follow this patient, because we treat a patient, we implant an endograft, and we follow more or less the patients, but we only follow the patients regarding the maximum diameters. And we know that the maximum diameters, maybe this is not the optimal option for following all those treated patients. And luckily, we are working with a startup in Bordeaux that automatically gives the maximum diameters, but moreover, the volume of the aneurysm, and especially after EVAR, and now we are working on after fever. That have been published, validated, and that also give you automatically in less than 2 minutes the evolution of the neck every 5 millimeters, and to see. This is one example here. In that case here, you see that the patients grow a little bit in terms of diameters, less than 2 millimeters, but that grew up also in terms of volumes, approximately 10% in volumes, because less than 2 millimeters, this is quite nothing in terms of diameters, but 10% in terms of volumes, this is more significant. And this is one case, for example. This is a case that have been treated previously, and you see here there is a beautiful hendolic here coming from lumbar arteries and going up into the IMA. And after the patient have been treated with tons and lots of coils and glue into the sac, and after that became very difficult due to the flash to follow strictly the aneurysm and to see if there is an increase or not. And this is how does it work. We put the angio CT scan control into the machine. You see the tons of coils flashing, and after directly and automatically that give you the lumen and also the thrombus, and after that give you the maximum, the amount of the volume and the maximum diameters. And this is what we received. This is the report, and you see that here, this is the diameter here, and you see that 2 years after, the diameters and moreover the volumes are increasing. Thus, we need to take care on that aneurysm. And moreover, if we focus on the diameters at the proximal neck, we see that also the maximum diameters at the neck level is increasing. That maybe we need to prepare for next coming type 1A hendolic, and maybe that will be necessary to extend in that case. The third point, of course, we need more evidence, especially the technical points. There's, to input a fever into an aneurysm, fever is always a composite of many stents. The major stents, this is the fever itself, that this is fenestrated body or more or less bifurcated fenestration component. Also, we add some legs, but to connect very strictly the endograft to the targeted vessel, we need to have some very specific bridging stents that do perfectly the job. And for the bridging stents, we have various types of bridging stents. We have the V12, the live streamed, from Bentley, the BGP+. We also have the Gore stent. We also have the wonderful and the marvelous eye cover stent, of course, and we are fun. And the rate of occlusion of the target renal or visceral arteries remains quite low. It remains at more or less 1% at short terms, but that may lead, especially this is a visceral artery, to more or less 1% of mortality. And during the mid follow-up, a intervention may increase up to 27 to 42% that could be observed. In 28% of cases, the interventions are linked to the endoleak at the level of the targeted vessel and connected the bridging stent due to poor expansion, due to tears, due also to stent fractures, and that have been mentioned by Nico, the distance to the wall contact that could be an Achilles heel in that indication. And in 11% to 13% of cases, also due intervention due to stenosis of occlusion of the bridging stents. That's why we need to have more evidence. Of course, finally, very few data are reported for that indication. The V12, we know that have been presented previously by the Eric Veron team with quite good results. But this is quite old registry with mixing fenestration, mixing also branches that is not very clear, and there are some composite of different type of stents. Also, we are waiting after the registry from Bentley using the BGP, and for the moment we still have a very old report. And what's for the use of the iCover, because in our units we use a majority of iCover for the bridging stents. Of course, that's why we are working on a physician-initiated registry involving multi-centers with very strict indication and very strict contraindications. And what is very important, in one fever, only using one type of stent, in that case, in that registry, only to use the iCover and not to mix iCovers plus some Bentley, plus some V12, that could be quite leading to some misunderstood. And also to have very precise and new endpoints. And this is the physician registry, and this is the primary objective. We have two primary objectives. The primary efficacy is to evaluate the bridging stent patency. This is defined as the rate of stent with absence of binary restenosis and occlusion at 12 months and also 2 years. And the second primary endpoint, this is the safety. And how to evaluate the safety of the bridging stent, this is so-called the absence of target vessel instability after implantation. That is defined, but the rate of patient with absence of target vessel instability, that means this composite endpoints of any branch-related complication. That means aneurysm rupture, death, occlusion, component separation, or intervention to maintain the branch. I mean, in that case, the fenestration and bridging stent, patency, or to treat a branch-related component separation or endoleak between the implantation and the endpoint here at 1 and 2 years. This is the inclusion period. This is the follow-up up to 2 years that makes sense, and this is the study durations. That have been calculated. This is the numbers of patients we need to implant in this physician-initiated registry, and this is the criteria inclusion, very, very strict, and moreover, this is the criteria exclusion. And this is, we will start in inclusion very soon during the next spring, and we will have the results after 3 years. Thus, why more evidence is needed for fever? Because tons of evidence are awaited in terms of indication. What are the pure case indicated for open surgery or endovascular treatments? Also, we need to have evidence in terms of strict and very scientific follow-up and how to evaluate perfectly the treated aneurysm, and ideal devices in terms of technical success, I mean implantation, and also efficiency in terms of prevention of complication during follow-up. also for the fever, but maybe more or less for the bridging stents. Thus, this is the road of exploration and validation that is open for the very near future. Thank you for your attention.
Thank you, Eric.
Sylvie.
It's yours again. But again, Nikos still in Paris. You have something to add to your previous presentation? Go ahead.
I just didn't finish it. I didn't finish it, so I wanted to.
Okay,
No?
so tips and tricks in fever. Make recommendations
very
to
much.
ensure successful.
So a few just tips and tricks as I was asked to present on the fever. I think the graph that is mostly used still in the market, although there are quite a few new players, is the fenestrated from Cook. That's what I have more experience with. That's what I'm going to show you mostly, and this is like the markers that we always see important. The most important thing when you want to have a successful fenestrate repair is to attach the fenestrations to the target vessels early on. And to do so, you need to understand how the fenestrations work. You need to know that where your four markers begin and where they are for each one of the vessels. And at the end, and this is the markers, four markers for the celiac, SMA, right renal, left renal, three markers which are three in the front, three in the back, and then you have to make sure that this graft is correctly positioned. So the first step is to always rotate to one side and make sure all the markers go to that side. Rotate to the other side, make sure that all the markers go to the other side, so you confirm your orientation and make sure that the graft is at 12 o'clock position. I always deploy the grafts in AP, and you also make sure that in AP position the markers are the way they are on your graft plug. This is how it looks like. This was a fenestrate device. After we have deployed the graft, you go into the target vessels using your standard catheters first, of course, with a soft guide wire, and then exchange them for a stiffer one. One of the catheters that I like, if I have a little bit more challenging vessel, is either the UF catheter or a sidewinder, as you can see here, which can help you get into a bit more challenging vessel. And then same strategy here, go ahead and position your stents at the position, exchange for a rosin wire, and then start deploying one after the other. In this case, an eye cover where you can see how nicely you can see the proximal and the distal markers. However, not everything is as beautiful as it can be in these images, and you can perhaps appreciate that in this case we're not able to see the right renal artery after we deployed the stent. So what do you do now? Go to the right, left, start rotating, bring it up, bring it down. So the most important thing is to stay cool, and if you don't have a fusion, then to first go and get a artery, secure another artery, because that will also give you an orientation on how you're going to move the graft up, down, right, left in order to get the other side. And in quite a few cases, when you have a sheath on one side, the whole anatomy changes or the whole position of the graft changes, and then you can go to the other side and have a better visualization of the other vessel and then get it right. And this is, of course, what also happened in this case. What is also important is to avoid catastrophes is, even if you are sure you are in the vessel, based on your fusion or based on your first angio before you catheterize, is once you catheterize, just do another angio where you're inside to make sure that you are not in an accessor or in a small vessel, and then you stand and you have something like that, which could be a huge problem. You can lose the kidney, of course. Another nice trick that I like using, especially for the celiac, which we know is one of the most challenging vessels, is the up and down technique, where you go to the seal of to the top of the stent, and then you use that as a basis in order to go lower and catheterize your target vessel. And of course, quite often we do that by using also the help of a balloon in the anchor technique, as it's called. My favorite trick in fenestrate repairs is the 018 wire, which you can do it, of course, by ordering a preloaded catheter, a preloaded wire that goes through the vessel. But I like doing this also by myself. So the trick is quite easy. You first, instead of catheterizing the vessel, if it's difficult, you first catheterize outside the fenestration. You put an 018 wire out of the vessel, and then this 018 wire provides you absolute stability, so the sheath comes right at the origin of the fenestration, and then you can do a double puncture of your sheath and easily catheterize the target vessel and get the stability you want to. This is how it looks like. You can see the sheath over here, the 018 wire going out of the aneurysm, and then the sheath always remains at the right position, and you can easily catheterize. So this is the cheapest and most effective steerable sheath you can ever have in a fenestrate repair. The balloon behind the graft technique is something that we have been using earlier. I haven't used this for years, to be honest. Just in terms of historical techniques, this is something that you can use if you are way out of your target vessel and you still need to get some room between your target vessel and the graft. This is how it looks like, and as I said, this is something we rarely do anymore. Some of the pitfalls you have to avoid is distracting the stents. Once you go in with your bifurcated body or with the iliac limbs, and this is something we do now by focusing on the renovisual segment when we go in with the further stents, and if needed, we go in and re-stent or reline these endografts. For the celiac, we all know it's the most challenging vessel to do from below sometimes, so we have a low threshold to go from above in these patients, do a snare and get a sheath from above, or even sometimes, to be honest, leave it uncovered in the first stage. This is usually the area of the graft that has a good seal in the aorta, and then come at a later stage from above and complete the repair from above. Big problems are always, we don't lose a lot of patients when we do these fenestrate branch repairs anymore. What we still see sometimes are these wire perforations and these wire dissections, which could be lethal for patients, especially if they develop subcapsular hematoma of the kidney. So you always need to be very consistent with your assistants when you have these procedures, and you have to be a well-trained team in order to avoid such stupid complications that might lead to a death of a patient. We always use a rosin wire. I very, very rarely choose an Amplatza straight wire with a short tip, but I know that when I use that, the first thing I say to my resident is, this is a lethal weapon we have in the patient right now, so be careful. And sometimes you have a dissection, of course, you have to extend. This is examples of renal wire perforations, which you can see. You can also, if you're aware of it, do a good angio at the end of your fenestrate repair and make sure you coil that. Don't rush, you can do stupid mistakes. In this case, I just took everything out, although I had forgotten to stent one of the fenestrations, so always take your time in such a case. We were able to go back in and redo it, but of course, take your time. It doesn't have to always be in 1 hour. This lot stents is something that we know with some of the stent grafts that are balloon mounted in a few companies. So bringing these stents, balloon expandable stents, over a sheath is of paramount importance. Also, when you withdraw, you need to make sure that half of the stent is behind the fenestration. So while if you have completely taken back the sheath and you withdraw also the stent, that the stent also doesn't catch while being withdrawn in the fenestration. This is also something that you need to be aware of. And if that happens, of course, you can work with quite a few crazy methods, or just deploy the graft a little bit more further down and try to save the situation as good as possible. Migration and these lot stents, that was one of the cases that I seen. Here you have to go back and do a relining. And one technique that I would like to show you, last but not least, is the bundle technique that we just got published in GVT. It can be used both for fenestration and branches. I'm sure cardiologists know this technique, perhaps some of you as well. If you have such a challenging vessel, as in this case, and you cannot get stability with an 035 wire, what we do now is we do a 018 or 014 wire, and then we put a second 014 wire and a third 014 wire, or we put two 18 wires, and these are as good as a stiff 35 wire. So instead of having a 35 wire that you struggle to get in, you have 2 or 3 014 or 018 wires and finish the repair. This is how it looks like with just one wire, and this is how it looks like with 2 wires in place, and this is the so-called bundle technique. Thank you very much, and this is a book I can recommend.
Thank you. Thank you for both presenters, speakers. So it's time to discuss or to make questions or comments from the audience. How many of you are familiar with Fever and Beaver in the audience? Please show your magenta car. Okay, quite, okay. Probably 20%? Yeah.
More?
More than 20%?
22?
25. 25%. Okay. Well, from you, you are satisfied about the bridging stand we have already in the market? Or probably we need something else? Who is satisfied? Please show the blue car. Only one satisfied? The rest are unsatisfied.
That's why we need to have some data.
You need some data. We need some more important stuff. Nikos, for branched, because for fenestration is to be clear, the choice is quite clear. It's a balloon expandable, cover stand, wherever you need it, with some kind of difference. But the branch is still, as you mentioned in your talk, a branch patency, especially for Reynolds, is still one of the concerns. What kind of solution? Probably hybrid stands, hybrid technology?
Well, as you said, we all know that the stents, the old technologies that we had available and that have been used in the past years are coming from completely different indications. So only in the past few years we have been experienced companies, also like iVascular, that has now come in the market with the knowledge that they have to develop their stents in that direction. So what do we need? I think also for the fenestrated is clear that we need lower profiles, so it's important to have stent grafts that are compatible with 6 French, like the iCover, also the Bentley, but the iCover has also very, very nice elements that are very suitable for the fenestrated repair. For the branched, I personally use for the renal arteries, which are the most difficult vessels in terms of patency, and still use the Viabans because they're flexible and they take the curves of the renal artery very nicely, and also the respiratory movements. But there we need a graft that is going to be flexible in the middle, have radial force at the ends, and still have a very soft delivery system that would allow it to take the curves, to also to not create angulation at the end of a stent, and also take the curve when we do these branch repairs from the transfemoral approach.
Okay, Eric, any
yeah,
comment?
I've got one question that could remain concerned. What do you think, what is the acceptable distance between the fenestration and the osteon of the targeted artery? I mean, it's more the case, this is for the lowest renal artery that could start into the aneurysm. That may lead to some mismatch, and maybe there is a lack of some improvements, or short squared angle, short branch that could lead also to and maybe to change the device. What is your
okay, the maximum distance between the fenestration and the target vessel, for me, it could be no more than 5 millimeter in the ideal situation. If you have more combinations of angulation, probably you need to change with the inner branch is another solution.
Yeah.
You need to cover a little bit more higher the aorta. But 5 millimeter is my threshold when you decide for a branched or fenestrated, especially if you have enough space for branched.
Yeah.
because you need some space for branching too. Or you have also the delivery, the sequential delivery of the deployment of the branches, one by one, coming from from the arm. This is a technique. It was demonstrated by a Colombian guy. He's also in the room here, over there. So it's another solution to play with. But probably we need more evidence for sure, because we don't have a robust recommendation from any single guidelines in order to recommend as the first choice for Justa or pararenal aneurysm fenestrated endograft.
Yeah.
Still, open repair is the first choice and the gold standard. So if we build up some evidence, probably we can, change a little bit, shift the paradigm, and to put the fever treatment as a first choice. But we need more evidence, more knowledge about that. That's true?
Yeah.
For you? Yeah?
It is. And also one part that is increasing, that we treat more and more fever in HEVR, and now fever in fever, and also fever in dissection. And the main problem remains the remaining lumen that may help you for cannulation, rotation, and stent placement. That could be quite very tricky in some cases. And this is increasing in parts and percentage of cases we treat daily.
Especially for quite young patients. That means with patients with life expectancy and longest life expectancy more than 10 years.
And especially fever after fever.
Yeah, because the durability still is a Achilles heel for the vascular repair.
You mean for the patient?
Yeah. The Achilles heel from the patient and for the surgeon too.
Yeah.
Any questions from the floor? Yeah, please introduce yourself.
Okay, I have a question for all your experts. I'm Dr. Alisha from Azerbaijan. What do you think? What is the reason that you give up on chimney or snorkel? And do you totally give up on these techniques and start doing fever or planning fever to all your patients, or you still choose chimney on some cases?
Chiver technique is still a player in some specific circumstances. Myself, in emergencies, play a role, and some kind of bailout technique, and coverage of the renal arteries accidentally during the regular EVA. But we try to escape in any elective case, because we have some, if the patient lives enough, you can revisit the Chiva more often than we expected before. And then you need to play with a BVAR inside Chiva. We have experience on that. It's not so easy, but iCover plays a good role because we have a lot of method. With the radioparameters of iCover, it's a little bit easier. What is your experience about the
visibility?
Of the iCover is much better.
Regarding the Chiver, we try to avoid the Chiver technique. Right now, we use it a lot, and now, also in emergency, we use in most of the cases the unmade fenestration or the Chiver and severe abdominal aneurysm. But in most of the cases, we try to avoid the Chiver because we have a lot of problems. The two main problems with the Chiver, this is the gutters that may lead to type 1A handling. That's its reality. And after patients are living longer and longer, and we need to, in most of those cases, we need to do radio, and to do radio in previous Chiva, that could be a nightmare. That's why we try to avoid. And also in emergency, we use a lot of unmade fenestration or physician-modified graft. That works very efficiently, and with the team, we do that very frequently.
So I think that's one of the main challenges that we have in general in complex repair in our complex patients, is to kind of try to figure out who is going to live long enough to justify a very complex repair, or to just doing an EVAR with in a compromised neck or doing a CVAR. I don't do CVARs for quite a few years now, unless we have an accidental coverage of the renal artery. But I've seen a lot of patients that we said he will not live 2 years, so let's do a compromise. And that patient comes 2 years later with a type 1 endoleak and a 10 centimeter aneurysm, and then you have to do something that you could have solved very easily 2 years earlier. So now we have reduced the mortality and morbidity of fenestrate EVAR to such a level that I think we can easily offer it to all the patients that we would be thinking for fenestrate repair. We also have low profile devices, so the issue of access is also very rarely a problem. So in my opinion, there's no arguments really anymore for cheaper.
No arguments besides the price, because the price is cheaper, seems to be.
But it's not
at the beginning.
At least in Germany, it's not reimbursed anymore.
It's not reimbursed in Germany, yeah. But if you add the reinterventions, then the prices increase a lot, you know. It's a nightmare. So go ahead, Doctor.
One question for Dr. Silipakis.
Introduce yourself, please.
I'm Juan Varela from Colombia. This afternoon I'm going to show the semi-sequential in my talk this afternoon. One question. When you use the Viabahn, it's for sure it's very flexible, but I am concerned about the radial force in the branch and in the artery. Do you fix, when you use a Viabahn, do you fix the branch with another balloon expandable stent, or you leave it and wait?
So when we use a Viabahn, we try to go completely in the branch. So we don't do the compromise of putting 2/3 in the branch. We really put it completely in the branch. What happens with, of course, with the Viabahn, we now have the 75 millimeter length in between for certain sizes. Until now, it was always too short or too long, so we had to combine the Viabahn with the balloon expandable stent anyway into the branch. Now that we have the 75, you can get quite good into the whole branch. And if I am plus 1 millimeter to the branch and I have the completely length of the branch, I leave it like that. If that's not the case, I put a balloon expandable stent on top. Regarding the distal landing zone in the target vessel, I always try to have 2 centimeters of 1 to 2 centimeters full into the target vessel. So if I notice that I'm just with a tip around the corner, I will extend a little bit with either a Viabahn or a self-expandable non-covered stent.
And the other question is about VVX. There are some comments in Europe about the dissection with the distal portion of the stent. So they recommend, like Dr. Verhoeven, to go with less than nominal and then go out. And what do you think about that?
So in general, I was scared before when I had a vessel, and I'm still scared, when I have a vessel that is a renal artery that is upgoing, and you go in an upgoing vessel with a stiff balloon, and you push it down, even for a second, then you have a risk of a dissection. And then you leave a balloon expandable stent with the edge against the vessel direction. I think that's something that you should avoid. One trick is to do what you said. Still, the problem is that this stent shortens a lot, and they also have type 3 end leaks. So in these cases, I would definitely say extending good into the artery and then putting a 2 centimeter balloons at the distal part where it lands in the artery could be a good way to go around that.
I need to close the discussion here because the time is up. So now is a coffee break. Thank you everyone for to keep here, and thank you all the speakers.
Welcome back, everybody, for the second part of this morning. We heard a lot of tips and tricks about FIVAR and BVAR, and now I think we're all quite curious to see how this is in practice. So I will invite Professor Riambo for the first case. He will present a FIVAR case and show us not only his tips and tricks, but also how the new iCover is really helping us in the further development of this quite challenging technique. So please.
Okay, thank you very much. Welcome again. So it's not, in fact, one single case. It's more cases, a collection of cases, just to illustrate how is the performance of the new stent graft, copper stent graft, in quite complex EVAR cases.
Okay. Okay.
Those are my disclosures. So that is a case of a trauma case, a very young guy that has a car accident, and we apply for this particular guy an Chinese device that is from Ancura, from LifeTech, and also we perform an in situ fenestration with needle for the left subclavian artery, and we apply for that particular case and I cover stent graft. You can see how nicely you can identify the markers over there in both sides, and that this is the follow-up. As you can see how is looking for this case, the trauma case. So it's one of the applications for this covered stent. And just to emphasize the accuracy and the precision on deployment, you play with this case, this is a fenestrated case in a common trunk for the superior mesenteric artery and celiac trunk, just to be sure that we can deploy inside the common trunk this device without coverage of the celiac trunk. So it's another advantage for for cover metal stents and also for eye cover. So another case with a 4 fenestrated case. You can see here the visualization on the screen is quite impressive. You can identify very nicely all the struts and even both edges of the stent, due to the fact that it has tantalum markers very nicely visualized on the screen. Another case of FIBA with a previous embolized celiac trunk was already very, very bad celiac trunk. And also you can see how is the visualization as well as the flexibility in this case, for the superior mesenteric artery. And also we got a capability to play for the celiac trunk, because it was a branch of the celiac trunk we previously embolized. And in this case, you can see how precise is the deployment of that. And the conformability is also interesting to emphasize the conformability for the superior mesenteric artery in those particular cases. Another, in terms to emphasize or to illustrate in a Chiver case, with the left renal artery, only one single chimney, and then you can be much accurate because you can identify all the time the proximal and distal edge of the parallel graph in this case. Also with BIVAR after Chiva, we also talk about in the previous presentation. This is a Chiva performed some years before, and then we need to convert the case with a BIVAR case with 3 different branches. In that particular scenario, it's quite important to identify your bar stent or your cover stent, especially both edges, just to be where is the landing zone inside the target vessel as well as in the branch, because you have a lot of metal inside, so it's important to be aware about the new stuff, the new metal stuff you are putting inside. Another application is that is a complex case with branches and also IBD, and you can see how accurate is the deployment, and specifically the very short shoulders of the balloon, as previously mentioned this morning. One of the advantages for the platform is to use the Oceanos 35 just to avoid any kind of extra oversizing in terms of length. So nice radiopacity and nice performance. So in fact, that particular device is a covered stent, eye cover, has one of the advantages is a low profile, starting at 6 French. The largest one are 7 French compatible, and high X-ray visibility, displacement resistance, shortening resistance, over-expansion capability, high radial force, flexibility, king resistance, and we need to wait for some kind of a clinical data oncoming in terms of material fatigue. We have bench tests, but also we need to be sure in the clinical scenario how is the performance in terms of material fatigue over years. Thank you very much for your attention.
Questions now?
So thank you very much,
Yeah.
Vicente. Let's have some discussion.
Discussion at the end, yeah.
At the end?
At the end.
Yeah. Okay, so...
Oh, you want? You
It
are the
says
moderator.
the organizers gave us the order to discuss now. So
Is now? Okay. Is
let's
now? Okay, discuss.
let's take some discussion from the audience. In the meanwhile, please come up and ask your questions, your experiences. One of the things that I found very interesting and very helpful with the new iCover is that you have the short length of 17 also for the 8 millimeter. And that gives us the option to go with very low profile also in the celiac, where sometimes a very short trunk. And the SMA the same. We used to have the old days, the Advantas, the 32s, and so on, which would take us over the curve. What is your preference in terms of length for the celiac and the SMA?
It's a good question for sure, but it depends on the case. For instance, I show you already one common trunk for the celiac and mesenteric artery. There's in a specific case, but we need at least, you need to go inside the target vessel at least 2.5 or 1.5 or 2 centimeters in length inside. So in terms of fenestrated, probably 37 could be, or 27 could be the shorter one for the celiac trunk. Depends also for the mesenteric artery in order to avoid any kind of competence with the natural anatomy or the natural angulation of the mesenteric artery. That is important to check before to leave without the wire. How is the performance between the balloon expandable stent and the natural artery, avoiding that kind of competence. And then sometimes we need to put another self-expandable stent just to avoid that particular mismatch. But for mesenteric artery, most often is 37 length for mesenteric artery, fenestrated graft. Yeah.
Mm-hmm. So I don't no questions yet. So in general, when you have to put, there's a question?
We have two questions. One
I don't see it.
One here.
The light is quite.
So I have to tell you that I found the 27, the short for the celiac and the SMA, very helpful because I avoided this curve of the SMA, and so the need of doing a relining has reduced very much. But of course, if you're not very accurate, I agree with you. You have the risk of jumping out of the fenestration. So the 17 might be very helpful, but you really need to have a good landing zone behind and be right on the spot.
Yeah. There's some questions from the floor?
Yeah.
Up there.
May I request you to tell the in situ fenestration technique for subclavian, just in a nutshell?
You are talking about the in situ fenestration case?
The first case you told, the light in situ subclavian artery fenestration.
How often?
No. Just
Elaborate on the technique. Elaborate on the technique.
Yeah?
To talk a little bit about how you do it.
How to do it?
Yeah.
Okay. Because you have the micro here, it's quite difficult to understand that. So, yes, good question. This Ancura device is from China, and also has in the you can ask for also for the device is a needle that is compatible with a 018 guide wire. And then I have all the cases registered. Probably I can show you later on. So you deploy first of all the graft, and then from the arm, you can play with a French sheath, the flexible sheath. And the device is the flow-through, is the name of the needle, has a balloon. And the balloon between the needle and the sheath, you have the balloon that fixes the position over the graft. And then you can perforate the graft very easily with three different lengths. I think it's 12, 17, and 22 millimeter deeper. So probably with the middle 17 is okay. And then you pass through with a 018 wire, make a hole with a 3 millimeter balloon, shorter one, and then we can apply with the stent. And that is quite easy and fast and an elegant, deployment. For in this case of emergencies, it's very nice. Yeah.
Thank you.
There was one more question.
For the trauma? For the trauma patient?
No, I think it's a long procedure, so you need a good anticoagulation.
You are talking about fenestration?
Yeah, about the procedure and the anticoagulation. What the procedure?
Okay, for the complex fever, we use the ECT control.
No, about anticoagulation, heparin.
Heparin, yeah, for sure. Yeah. During the procedure.
The dose, first dose.
Is 1 milligram per kilo.
Yeah.
Yes, then you have the control each hour by the ECT, and then we need to perform between 200 and 250 seconds ECT control all the time. And then we check again if it's over the 200 or over 180. Then we perform some kind of, a transformation with protamine. Yeah?
Please, there's a question.
Dr. Tekiropoulos from Thessaloniki, Greece. Regarding the traumatic injury of the aorta, when you put the eye cover stent, do you flare the proximal part of the stent in order to be more steady in the thoracic graft?
We flare proximally and distally because sometimes the whole of the fenestrated should be less than 8 millimeter. 8 millimeter, no more than 8 millimeter, just to avoid any kind of tear of the fabric. Okay? So we play with an 8 millimeter balloon, but sometimes cover the stent, but sometimes the subclavian artery is larger than 8 millimeter. Then we flare with 9, 10, whatever. Up to 12 is in the IFUs. Even up to 14 you can play it. Inside is just 1 or 2 millimeters larger than the 8 millimeter. So 9 millimeter is enough. Yeah. No more questions?
So regarding the flare, Vicente, have you had how much do you flare on top to the nominal diameter of the stent? And have you had any issues when you flared above 2 millimeters?
I prefer to stop at 2 millimeter oversizing the flaring because you can avoid then any kind of fracture or any kind of, even shortening of the stent. In order to be honest, with this kind of device with eye cover, the shortening is very rare to observe. It's quite, stable in length. But 2 millimeters is enough in order to, if you play with a 6 millimeter bridge stent, 8 millimeter balloon for flaring is enough. Putting the marker inside, the fenestration, inside the target vessel, and then to flare with a balloon 9 or 8 plus 8 for 2 centimeter. Yeah.
Excellent. Any more questions? One last question. Please identify yourself.
Thank you. Vladimir Baron from Colombia. Dr. Nikos, what's the minimum size that you recommend for stenting? I saw the case that you showed with the multiple renals, but they look very, very tiny actually. And the second question is how much do you oversize the stents for the renals, the celiac, the SMA usually?
It's for you, Nikos, or I can answer you.
Everybody, yeah.
Yeah, the minimum diameter to be stented is 4 millimeter. Less than 4 or 4 is a bit challenge because the lowest diameter we have is 5 millimeter. Then it's better to play with a larger target vessel than 4. And then for the second question, it was regarding
the oversizing of the stents.
For the target vessel?
1 millimeter?
There are 2 methods. One is to be nominal, 1 by 1, but it's difficult sometimes to calculate that. But always I try to inflate the balloon up to 12 atmospheres. If not, it's the case, I prefer to go, larger with oversize, 1 millimeter oversize. For 5 millimeter renal artery, I play with a 6 millimeter stent. I try to escape 5 millimeter stent because are much more prone to be occluded over time. 6 millimeter stent is very good.
Okay, thank you.
Yeah, the same thing that we do as well. We try not to oversize too much. Sometimes when you're in the verge, you just take like one by one and then over-dilate the stent.
Yeah.
And if you have a leak, you can always go with a 1 millimeter bigger balloon and kind of do the apposition. And what we really try to avoid is too much oversizing because you have also the balloon effect on the distal part, and you can see the spasm of the renal arteries after you kind of overdo it.
But again, it's very important to play with balloon with not big shoulders. So, with a very nice small shoulders, because you have the markers and then the balloon is a little bit larger. So, Oceanus is a good player in these particular cases, to oversize and to over ballooning with shorter shoulders. Okay.
Okay. Thank you very much.
Okay. Thank you.
Okay, so let's move on to the next talk. So, I'm Dr. Masako Fujihara from Japan, Osaka. So I'm very happy to hear. And next speaker is Dr. Ralph Rangoff. Unfortunately, he is not here due to the flight arrangement trouble. So yeah, so he's on screen, so on web. So Ralph, can you hear me?
I can hear you quite well, thank you.
Yeah, so please start your presentation.
Okay, yeah, just thank you for having me. I'm very sorry, I'm just coming from a very small city called Berlin, where a strike is just destroying the entire transportation system. So I was not able to come neither by car, train, whatsoever, so no chance. Okay, so I maybe just, can you see my screen?
Yes.
You can see it. Okay, super. Yeah, so my deal was to do an iliac complication case, but I think you have all seen iliac perforations in your life. So as the topic is a little bit about covered stents, fevers, EVERs, I just thought that I may took something like this out of the box, which is a little bit different, and it should be interactive, so I probably need your help. So I can tell you I hate endoleaks, definitely, but I definitely love my vascular surgeons. So I'm a little bit part of the cleaner in case something with EVARs, fevers, whatsoever, side branches is going wrong. So I may support my colleagues there. So no matter what happens, we stay together. It's just like, so we are just having a very good cooperation in these topics. And I want to share a case with you. So I think it's a durable situation with EVARs, fevers compared to open surgery, but these patients need more investigation and sometimes redo cases, especially for these endoleaks. So my case is an 80-year-old guy, male patient. The story is from January 2020. He's got an abdominal aortic aneurysm and a huge internal iliac aneurysm of almost 7 centimeters. He has a lot of comorbidities, pulmonary embolism, arterial hypertension, an umbilical hernia, obstructive lung disease. So that's why the idea was to do this not by open surgery, but just to take care by endovascular approach here from my surgical colleagues. So they planned to do an EVAR with an iliac side branch, zenith alpha plus ZBIS from Cook, and a long Viabahn into the iliac side branch. So these were the images. Here you see this huge abdominal aneurysm, and you see on the other side this very huge, almost 7 centimeter large aneurysm of the internal iliac artery. Here you see the other views, so just good landing zone for the abdominal and also a landing zone for the distal internal side branch. Here you see that was just a good option not to close everything with the Viabahn, just to have a good landing zone here. So that was the last shot of the implantation from my surgical colleagues. Zenith alpha prosthesis with a ZBIS and the long Viabahn into the left internal. So I would say, a very good image and a very good solution for this. So the patient had an enhanced, contrast-enhanced sonography, and there was also a suspicion already of an endoleak, and we did a CTA in June 2020. You see here, there is an endoleak in the aneurysm, and probably it comes from the inferior mesenteric artery, and there's also a lumbal artery here feeding this inflow, respectively outflow situation to support this endoleak. So the idea was, okay, so, sorry, and there was also a second endoleak here, but not that huge, in the distal part here of this internal left aneurysm, also an endoleak here. So the idea was to do a transfemoral coiling of the lumbal artery and the inferior mesenteric artery here via the gastroduodenal artery and the rheolane arch, and then also may take care of this small aneurysm in the internal iliac. So what we did, we went transfemoral. You see here the rheolane arch feeding the mesenteric. So we were super selective going in there. You see here this endoleak coming from the inferior mesenteric artery. We then took in a microcatheter and then started here to embolize these lumbal arteries, which are forming the outflow probably or the inflow. We closed them with coils, and then we just also took care of the offtake of the inferior mesenteric artery by coiling, which was sufficient. So then the question was, so what is going to happen with the second endoleak? And you see here very small arteries, and we were coming from the groin here. We tried to get in with some catheters, microcatheters, just to get, you see here the endoleak, to get into these feeding arteries, and I can tell you, we failed. We were not able to get anything around these curves and just find the right spot to go into these small arteries to place also some glue or coils into this endoleak of the left internal. So then the decision was to do what you can also do, just like a CT-driven approach to puncture the internal iliac artery on the left side with a dyna CT in the hybrid OR, and just to directly put onyx inside. And that was just the images here. You see the needle coming and just approaching the very close to this viabahn. But I can also tell you that that was just a cooperation with our radiology department and with the vascular surgeons. So they failed. Yeah, so esteemed vascular team, what to do now? Do you have any idea? So we just were able to close the endoleak in the abdominal aneurysm, but we still have this 7 centimeter huge aneurysm with an endoleak here, and there was just no shrinking of this, so the decision was to take care of this. Any idea what to do?
So, Rolf, why didn't the puncture work?
Well, because I was not around. No. No, I don't know. I cannot tell you. So I know that my radiology guy, he's really excellent in puncturing a lot of things, but he failed. I cannot really, I have no explanation why this failed, but they were not able to. And he's got a lot of patients, but he gave up.
And the stent is in the superior gluteal artery?
The stent is in the superior gluteal artery, right?
Yeah.
Okay.
Any chance to go beside the stent through the IBD?
Good idea, but it's a long way. So the aneurysm. So can you see my arrow?
Because that's something we do when we have a sac problem. Mostly when
So
it's the sac.
it's like the length is like around about I would say 6 centimeters going into this, very close to this via barn. And just, we didn't probe, but that would also be an idea.
So puncturing the superior gluteal artery could be also an option, but that would get you in the stent probably. But that's also an option to go next to it and try to embolize next to it, next to the superior gluteal artery from a transgluteal approach.
Also,
Do you have any kind of dynamic imaging, like means a dynamic CT, in order to localize much better the origin of the leak?
So there was not a dynamic CT, no. That was not done. It was just like a CT scan, and they did this Dyna CT was in the OR. But that is just like from ZGO, so I would say the quality is not so high.
Because the suspicion is a type 2 endoleak, still is a type 2 endoleak, yeah?
So, Ralph,
just coming from a side branch, so maybe just to the sake of time.
Excuse me. Did you have any angiography of the profunda and the common femoral artery to see if you have collaterals with the profunda? To go from the
we just had images. I didn't share them, but there was nothing coming from the profunda to this side branch. So everything was coming, and I show you just images very well from the contralateral internal via some dominant arteries, but we were not able to get in. So our idea was right now, because we just once failed to go via these small collaterals into the contralateral internal and just go to the other side. We just tried for another approach. So we went for transbrachial access. So the other one was transfemoral. So the strategy was to use a 90 centimeter 7 French access via the left brachial, a 4 French access from the common femoral, just only to get some better imaging where this endoleak in the left is. So we then was the idea to puncture the prosthesis, so the via barn with the BBAC system, just with the reentry system, just to really to poke a hole into this side branch, and then get a microcatheter inside, try to embolize from the original lumen, and then seal and reline the iliac side branch with the covered stent. And as a backup, it's always good to have a friend. So that's my vascular surgeon, just drinking and observing us how we struggle. So just for those who are not familiar with the go back and forward times, right now is BBAC from Bentley. So it's just like a 4 French needle device, which you can control the needle. So it's quite a long length of the needle, just almost 1.5 centimeters. And you can steer it and just try to get access to whatever you like. So that is the access via the subclavian. We then went very easily into this side branch, and what you can see here right now is just the imaging of the contralateral internal. You see quite a large endoleak here, and just also strong arteries going in and going out of this endoleak. So you see here, so we went in with this BBAC system, punctured the via barn, and destroyed at least our stent here. We then put in a microcatheter here, and then started with coiling. We put in several coils, and we also tried to go into side branches, which was not so easy to control because the length was not really nicely, and so the support from the catheter was not the best one, but we were able just to put a coil into the left, respectively right outflow situation, and just a lot of coils into this endoleak. But I can tell you, still too strong flow. It did not occlude within our situation. And as the patient was quite old and we did a lot, we thought, okay, just try to go from the other side and see, just in terms of imaging, is there something we can really maybe just try to do better then? And you see here small side branches which are feeding this artery. And as we not try to give up, we just went into this gluteal inferior artery on the left side and used several catheters. First of all, it was a cantata microcatheter, which we were not able to get in. Then we used Japanese product. It's a carnelian from Tokai Medical, a support catheter, which went on the contralateral side, and then we were just almost in this endoleak here. We then started with coiling via this cantata microcatheter here, and that was just very good, almost very good results. Then what always happens, so then we just had a perforation of the side branch, some bleeding, and then we decided to close everything. We then put in coils and coils and coils, stop this bleeding event here, and that was just 13 coils later, stop of the bleeding, so no filling of this aneurysm sac. We were just able to seal it here, and then we just had to close the hole, which we eventually put in here just to be safe that there is no blood flow coming from the original internal left. So we put an eye cover stand here 8 millimeters just to seal the Viabahn here and close the hole. We punctured with B-back catheter. That was just the final image here after using this eye cover into our hole and just the still good flow into the peripheral of the internal without any endoleak here from the other side, and also CT scans showed that we were able and succeeded. Outtakes and making off, so that was just our table. As you see, a lot of material, a lot of wires, and a lot of sweat from my side, so I was physically destroyed, but I can tell you, I really love my vascular surgeons. Thank you.
Thank you.
Thank you for a great, tough case. So please start the open discussion. So from the audience.
So if you go to the microphone, I can hear you.
Thank you for your nice case. The question will be like the transbrachial or the transradial access is the best, actually, the option that you have discovered. That's what I was trying to offer you before. But why did you do your best to keep that internal iliac artery open from the beginning of this case? Like you could just do a sandwich coiling instead of putting a Viabahn there and dealing with all these complications. I just didn't get that part of your case. Why you did your best to keep that internal iliac open?
So that's a question from a vascular surgeon. So mostly if it is possible to keep them open, so they try to keep it open. Definitely because the other side, there was a patent iliac internal from the other side. There would definitely be an option to coil everything just from the very start and to sacrifice this internal. Retrospectively, I think it would have been the more easy case to do this. The patient was 80 years of age, so when we started this procedure, so probably he will be not a jogger or runner just for gluteal claudication, but I think the point was that the vascular surgeons saw an option to easily save the internal, so that's why they did it.
So if I may comment on that, I think the decision to keep the internal always, whenever you can, is a good decision. It's also recommended now in the 2024 US ESVS guidelines to try to preserve both iliac arteries if possible. And at the end of the day, putting an iliac side branch and then putting a stent graft in the internal iliac artery is as cumbersome as trying to come in crossover and trying to get all the side branches of the internal iliac artery, and at the end of the day, the same work. So I think that's absolutely the way to go.
Just a question, Gilles Goyot in Strasbourg. Why didn't you choose to use onyx instead of coils when you managed to cross the Viabahn? Because I think we would have spared some time and sweat, probably, and you could have reached more easily the side branches, no?
Yeah, so there are some payment issues in Germany in terms of onyx, so it is not reimbursed so far. Okay. So it's just like a gift to the health insurance system.
It's a good reason.
Yeah, it's a bad reason, but it's at the end.
That was exactly my suggestion, to go with onyx probably from the first time. Transgraph and onyx later. Yeah. Old combination, coils and...
Rolf, one question for me. Usually when you put a stent graft in the superior gluteal artery, you leave the inferior gluteal artery open, which is a backdoor for type 2 endoleaks. And we choose to do that primarily in the first operation. Why did you decide primarily not to coil embolize the inferior?
So because I think all these backdoor situation was just coming from the contralateral side. So there was, I think, no filling of this aneurysm sac from the ipsilateral side. It was everything was just coming from the contralateral side.
Excellent.
So, yeah.
Thank you very much, Rolf, for the great case.
Thank you. See you later.
Very, very nicely solved, and very, really elegant way of going around a very tough complication that bothers us quite a few cases. And it's my honor now to present Caroline Caradou from Bordeaux University, who is going to present us also a fever case, and we're excited to see your case, Caroline.
Thank you for the kind introduction and for the kind invitation. So it's going to be a few cases, actually. This was our first case with the iCover stent as bridging stent in our unit. It was back in 2021. So this was an 80-year-old gentleman. He had a history of prior aorto iliac Dacan graft, and he had a proximal evolution of his aneurysmal disease and presented with a tender aneurysm. He had already an occluded celiac trunk and an occluded left renal artery. So our plan was to do a TEVAR and to do a physician-modified graft with just 2 fenestrations to preserve the remaining arteries. So this was our old setup. We just had a C-arm at the time, so you will see that we were quite happy with the visibility of the stent when we didn't have better imaging. So this is the modification of the graft on the backside table. We already implanted the TEVAR graft, and this is the deployment of the physician-modified device. So we do a few diameter-reducing ties to have a little bit of room remaining between the aortic wall and the graft. And then this is the way that we usually cannulate our arteries. So we use a thermo wire, and then we exchange that for a rosin wire to have more support. Put 6 French or 7 French sheath, depending on the size of the stent that we want to implant as a bridging stent. And then we check that we're inside the right target vessel, and we check for the bifurcation of the vessel to know the length of the stent that we're going to use. We proceeded the same way for the SMA. This time we used the 7 French sheath because we wanted a larger diameter bridging stent. And this is the checkup of the target vessel. Then we proceed with a latex balloon inflation. This way we kind of disrupt the diameter reducing ties and reopen the graft completely. And we started by stenting the SMA. So you can see here the iCover bridging stent coming into the sheath. So what we like with this stent is that there's no problem with the crimping. So you can move your sheath and move your stent even without the sheath, without losing your balloon or having the stent gliding over the balloon. Then we inflated the stent at nominal pressure. You can see here that there's a rapid inflation. The stent is quite flexible. And then we use a swallow maneuver to re-enter into the stent with the sheath, which is quite easy also with this balloon platform because the deflation is quick. Then we flared it at 10 millimeters. Usually we use 1 or more or 2 millimeters more to flare the stent. Swallow maneuver as well. And we check that everything is patent. So we proceeded in the same way for the right renal artery. You can see here the flaring of the stent. So we flared it at 8, then 9 millimeters, because the the fenestration that we did was a little bit larger than what we expected it to be, so we had to flare it a little bit more, but no problem with this platform, and no difficulty taking out the wires, and this is the final result. So we've been using the iCover stent as a bridging stent ever since for our FEVAR, so it's no surprise that when we moved in last week in our brand new surgical floor, that's also what we used for our first FEVAR case there. So this is an 86-year-old gentleman, prior history of CAD, pulmonary embolism, so obviously not a good choice for an open repair. And the plan is to do a 3-fen device, because he's an old chap, so we think that it's going to be enough for his remaining years. We just wanted to stent the 2 renal arteries and to leave the SMA unstented. So this was our new setup. We also had an iliac artery aneurysm, so we wanted something simple because he was an old gentleman, so we didn't preserve this internal iliac. So we just plugged it and occluded it, and this is the FEVAR device that is advanced in the patient. So standard way to cannulate, as I told you, we always proceed in the same way. And here you see the iCover bridging stent coming into the sheath. So you can see that it doesn't move onto the platform, which is quite nice compared to other brands. And here is the opening of the stent in the right renal artery. So it's a 6 by 27 millimeter stent. So this is the stent before flaring. We flare it with an 8 millimeter balloon. And this is the control angio of the target vessel. And you'll see here the difference between before and after flaring. So you see that there's no shortening of the stent, which is quite nice, I think. And here's the stent deployment of the left renal. So it's the same as 6 by 27 millimeter stent. Our intern wasn't quite focused on the procedure, so lost the wire for a while. But you see that there's no problem re-entering the stent, so that's also quite nice. Then flared at 8 millimeters. And control angio of the target vessel. And final control with the bifurcated device. And this is the case of the week. So this one is a fenestrated trio device. This is a 75-year-old gentleman, prior history of open aorto bifem repair in 2011, CAD, type 2 diabetes, and proximal evolution of his neurosmall disease as well. So you see here what's happening with the graft. So we targeted the target vessels quite easily. So right renal, then left renal. Now the SMA. Inflation of the aortic graft. So we have 2 sheaths at the moment because we only had a 60 French sheath on the left side. And this is a big graft stent that we have on the SMA, and these are going to be 2 iCover stents for the renals. And you see here that with the big graft stent, you actually don't really see the stent, even with good imaging. It's quite difficult. Yeah. And you'll see the difference afterwards when we put in the iCover stent. So we really think that visibility is actually a really good feature of this device. Here is the iCover stent advancing into the left renal artery. So you see that with the markers and the increased visibility even of the struts of the stent, it's quite easier to see what you're doing. So we had to put another stent because we were a little bit too short into the aortic graft. So 2 stents there. Flaring of the stent. And reconstruction of the remaining right renal artery. So we keep in the wire on the other side just in case that the two stents actually enter into a competition there, but no problem, as you can see. Flaring of the stent as well. Quite a nice result there. So no problems with the target vessels. We take away the wires, proceed with the rest of the procedure. So we implanted the bifurcated device because the triophane is actually already bifurcated. So we prolonged the graft into the ancient Dacron graft to have a complete repair and relining to make sure that there's no leak there. So that's what you see here. And this is the final control with the Conbeam City. So you see that there's a nice result. Here, no problems with the structure of the stents. So in conclusion, why do we like it as a bridging stent? We like the platform of the Oceanus balloon because, like I said, we've got excellent crimping, quick deflation time for the swallow technique. We like the visibility, the flexibility of the stent. The post-expansion capabilities of the stent, more than 2 millimeters, which is quite nice when you need to flare it. And of course, the low profile, because you can go all the way to 6 range for an 8 millimeter stent if it's not too long. So quite nice for the celiac trunk, for instance. Thank you for your attention.
Thank you very much, Caroline. Amazing case, very interesting, both of the cases. Are there any questions from the floor?
Did you use the Advanta device for the mesenteric just in purpose to compare the visualization, or was another kind of reason?
So we didn't have the proper size with the iCover
Okay.
stent. So that's the reason we used it. But we thought it was a nice case to
But you got a good example of,
show the difference,
to compare visualization of
Yeah.
both different kinds of threat marks. Yeah? Okay.
Would you have any concerns going also bareback with the eye cover? Into the target vessel. So we always say balloon expandable stents need to go over a sheath and to secure. It seems that eye cover is much more stable on the balloon than other competitors. Would you have any concerns also going bareback, so without the support of a sheath into the fenestration, or would you not recommend that?
I still use the sheath to protect it for the fenestrated devices, but if it's like an iliac recanalization, I don't necessarily protect it with a sheath, which is something that I always did with other brands of stents. So I think it's actually really tightened onto its balloon, but I've never tried it without the sheath for fenestration.
For branches, would you do it without?
So for branches, we've used it, and we don't place the sheath into the target vessels. For branches, it doesn't move, yeah.
Okay.
I wouldn't be worried about the sticking of the stent. I would be more worried about the edges of the stent.
Yeah.
That when they hit something, they tend sometimes to
You
make
open it.
little hooks, and
Yeah.
then you got problems finally to get in.
To be stuck it.
Yeah. Because I had that before.
So, but the general recommendation is to be protected all the time, especially if you have already the sheath inside. So to put inside the target vessel makes sense. Otherwise, the complication is a little bit nightmare.
Yeah.
The dislocation of the stent. Yeah.
Excellent. If there are no other questions from the floor, I think we're a little bit behind time, so thank you very much for the amazing presentation.